There are 5 routine tests you should never accept after 70 without asking 3 specific questions first. His daughter called it the year of routine checkups. He was 72, still driving himself to appointments, still tending his tomatoes every single morning. His doctor described him as stable. By every measure medicine uses to evaluate a man his age, he was doing well. Then came the year of routine checkups, the year that changed everything.
One test led to another. A result came back elevated, worth a closer look, the doctor said. The closer look required a procedure. The procedure revealed something small, slow-growing, the kind of finding that in a younger man would warrant treatment. Something that in a man his age, the research would later suggest, had a low probability of ever causing harm during his remaining lifespan. But that is not what he was told. What he was told was, we found something and we need to take care of it. The treatment had side effects. The side effects required medication. The medication interacted with something else. The interaction required monitoring. The monitoring led to a hospitalization. And somewhere in that chain, that long, carefully documented, medically appropriate chain, the man who had been tending tomatoes every morning stopped being able to walk to the end of his driveway. 12 months after the year of routine checkups began, he was in a rehabilitation center. Nobody had made a mistake. Every step had been appropriate. Every physician had acted within the standard of care. What the system was not designed to tell him, what nobody had explained before the first order was written, was that a routine screening test in a man his age could initiate a sequence that medicine would call successful and that his family would call the year everything changed. That sequence has a name. It is called the Cascade Effect. My name is James. I research evidence-based medicine for adults over 40. I am not a physician. This is education, not medical advice. Every decision requires a conversation with a clinician who knows your individual case. Before we go any further, drop a comment with just your age, nothing else. I want to see who is watching this. There is a body called the U.S. Preventative Services Task Force, an independent federal panel that evaluates screening tests and issues evidence-based grades. A D grade means harms outweigh benefits, and the task force actively recommends against that test for that population. For 5 tests that millions of Americans over 70 receive every year, the USPSTF has reached conclusions very different from what most patients are told. Nobody explained that the mathematics of screening change after 70. Nobody said that the cascade following a positive result can cause precisely the harm the test was designed to prevent. That gap between what the research shows and what is happening in clinics across this country is costing people the one thing no lab value can measure. It is costing them their independence. That gap exists because of a structural disconnect nobody explains before the appointment begins. The physicians ordering these tests are not acting in bad faith. They are following practice patterns built when the evidence looked different, before the data on adults over 70 was analyzed separately, before false positive rates in older populations were measured against the realistic remaining lifespan of a 75-year-old with 2 chronic conditions. The system was built for one population and being applied to another. Has anyone explained to you, before ordering a screening test, what the specific risks are for someone your exact age? Has any physician walked you through what happens if the result is positive and what the chain of follow-up procedures might look like? If the answer is no, you are not alone. And the first test on this list, the one with a Grade D recommendation that half of American men over 70 receive anyway, is where we begin. Consider 2 men, both 71, still healthy for their age, both with a PSA result that came back slightly elevated at a routine checkup. Both results were legitimate, both physicians were competent, both men received the same information about what had been found. The first physician said, "We need to follow up. Let's schedule a biopsy." The second physician said, "Let me show you something first." He explained that for men over 70, the U.S. Preventative Services Task Force has concluded that the harms of PSA screening outweigh the benefits, a Grade D recommendation, their strongest level against a test. He explained that many prostate cancers found in men over 70 are what researchers call clinically insignificant, slow-growing tumors that would never cause symptoms or shorten a life. That data is built on long-term, large-scale studies, the sort of conclusions that medicine calls overdiagnosis, which means diagnosing a condition that never would have become a problem.
He explained that the PSA false positive rate approaches 50% in older men. He explained the treatment consequences. About 1 in 5 men who undergo prostatectomy develop long-term urinary incontinence. 2 in 3 experience long-term erectile dysfunction. More than half of those who receive radiation deal with lasting sexual side effects. Then he said, "Given your age and overall health, I think the right approach is watchful waiting with close monitoring. We do not intervene unless something changes in a way that changes the calculation." The first man had the biopsy. Cancer was confirmed, low grade. He proceeded to treatment. He is alive today, which his physicians consider a success. He also wears a pad every day and has not had a sexual relationship with his wife in 3 years. That is not something documented in the chart. The second man never had the biopsy. He is also alive. He still tends his garden. He and his wife recently celebrated their 47th anniversary. Same PSA result. Same age, 2 conversations, 2 completely different futures. Nobody told the first man that the second conversation was an option. A study published in JAMA Network Open in April 2023 by researchers at the University of California, San Diego, found that nearly half of American men over 70 have received a PSA test in the previous 2 years, despite that Grade D recommendation having been in place since 2012, reviewed multiple times, and reaffirmed each time. The problem is not negligence. The incentive systems, the institutional habits, and the liability concerns that shape clinical practice are not aligned with the evidence. A physician who orders a PSA and something is found is protected. A physician who does not order it and something is later found is exposed. That asymmetry drives behavior, regardless of what the guidelines say. And the patient sitting in the exam room has no way of knowing the decision may be shaped by factors that have nothing to do with his individual best interest. Now, let me tell you about a woman named Margaret. Margaret was 77. She had been getting mammograms every 2 years since she was 50. At 77, the mammogram found something, a small cluster of cells, low grade, slow growing. She proceeded through surgery, radiation, and hormonal therapy. 14 months. She lost significant physical strength. Her cardiac medication required adjustment 3 times due to drug interactions. She developed a secondary infection requiring hospitalization. 2 years after treatment, a geriatric oncologist reviewing her case for an unrelated reason told her daughter something Margaret was not in the room to hear. Based on the pathology, it is very likely this cancer would never have grown to the point of causing symptoms or shortening her life. The treatment she received was appropriate for a woman of 50. For a woman of 77, watchful waiting may have been the better path. This is what researchers call overdiagnosis. The National Cancer Institute published a study in the Annals of Internal Medicine in 2023 that quantified this risk. For women between 75 and 84, the estimated overdiagnosis rate with routine mammogram reaches 47%. Nearly half of cancers detected would never have caused harm during that patient's remaining lifespan.
The USPSTF classifies mammogramming in women 75 and older as an I statement, insufficient evidence to determine whether benefits outweigh harms. And yet a 2025 analysis found that 9 out of 10 top cancer centers in the United States do not specify any upper age limit for mammogram in their patient-facing guidance. 9 out of 10. Drop a comment. Have you or someone you loved been through a screening process that led somewhere unexpected? Before I get to the third and fourth tests, I need you to understand the mechanism, because what I am about to show you will reframe every screening appointment you have ever had, and it will make the 3 questions at the end of this video the most useful thing you take away from it. Here is the mechanism. A screening test is designed to find disease before it causes symptoms. For the right patient, at the right age, with the right health profile, it saves lives. The evidence for mammogramming in women 50 to 74 is real. The evidence for PSA screening in men 55 to 69, done with full informed consent, is real. Colonoscopy in adults 45 to 75 reduces colorectal cancer mortality across decades of clinical data. The issue is not the tests. The issue is what happens when those tests are applied to a population the evidence base was not built for, and when the cascade that follows a positive result is more dangerous than the disease the test was designed to catch. Write this down. A screening test is only worth its risks when 2 conditions are true simultaneously.
First, it finds something real, not a false alarm, not a slow-growing anomaly that will never harm you. Second, finding it early actually changes your outcome. You live long enough for treatment to matter more than the harm of the treatment itself. After 70, both conditions become less reliable, and nobody explains that before the order is written. Consider the carotid artery ultrasound. This is a test that looks for narrowing in the neck arteries that supply blood to the brain, narrowing that could theoretically increase stroke risk. It sounds protective. It sounds like exactly what medicine should be doing. The USPSTF has a Grade D recommendation against this test in adults with no symptoms, no history of stroke, and no neurological signs pointing to the carotid arteries. Reaffirmed in 2021. Harms outweigh benefits with moderate certainty. The American Heart Association and the American Stroke Association reached the same conclusion. A man named Robert was 68. High blood pressure, well controlled, elevated cholesterol, managed, no symptoms. His internist, thorough, well-intentioned, ordered a carotid ultrasound as part of a comprehensive cardiovascular screening package. The ultrasound found significant narrowing, 70% stenosis. A referral was made to a vascular surgeon. The surgeon recommended carotid endarterectomy, surgery to remove the plaque from inside the artery. Robert had the surgery 3 weeks after the ultrasound. The surgery was technically successful. On the 2nd day after the procedure, Robert had a stroke, left side weakness, 6 weeks in acute rehabilitation. He recovered partial function. He has not driven a car since. Here is the mathematics that the USPSTF published. The annual stroke risk in a patient with asymptomatic carotid stenosis detected by screening, no symptoms, is approximately 1% per year. 1%, with aggressive medical management, statins, blood pressure control, antiplatelet therapy. The 30-day risk of stroke or death from carotid endarterectomy at the best surgical centers in the country, 1.4 to 3.5%. For carotid stenting, 2.6 to 5.1%. The procedure meant to prevent the stroke caused the stroke, and this is the documented peer-reviewed rate at excellent centers. This is not malpractice. This is mathematics.
The pattern repeats with colonoscopy after 75 in patients with multiple chronic conditions. The preparation requires high-volume liquid laxatives over 12 to 24 hours, uncomfortable in a healthy 50-year-old and potentially dangerous in a 78-year-old with reduced kidney function, where severe dehydration and electrolyte imbalance are real risks. Perforation risk increases with age, and the lead time to benefit from early polyp detection may exceed a patient's realistic remaining life expectancy when multiple chronic conditions are already competing for that future. The USPSTF is explicit. Adults 75 to 85 should make individualized decisions. Adults over 85 should not be screened routinely, not because colorectal cancer stops mattering, but because the mathematics of who benefits changes in ways the routine appointment does not pause to calculate. The fifth test, cardiac stress testing in asymptomatic adults with no cardiovascular history, follows the identical logic. A woman named Patricia was 69, no chest pain, no shortness of breath. Her internist, concerned about her family history of heart disease, ordered a treadmill stress test as part of a thorough annual checkup. The result was ambiguous, not clearly abnormal, not clearly normal. She was referred to a cardiologist. The cardiologist ordered a nuclear stress test. That result also came back borderline. She was referred for cardiac catheterization. During the catheterization, she experienced a minor complication that required overnight observation. She was discharged the next day with a clean bill of cardiac health and a medical bill that took 2 years to resolve. She had arrived at her annual physical feeling fine. False positive rates in older adults are high. A positive result triggers referral. Referral leads to catheterization. And in a patient who arrived feeling fine, the cascade has already started before anyone asked whether it should have. 5 tests, 1 mechanism, the same gap, the same chain, and the same 3 questions that interrupt it before the first link forms. Everything I have told you could leave you with one of 2 responses: fear and a reluctance to engage with any test or any physician, or agency. I'm asking you to choose agency. Here is what that looks like in practice. A woman named Carol was 71.
At her annual appointment, her internist handed her 2 referrals, a colonoscopy and a carotid ultrasound, printed and ready before she had finished sitting down. Carol did not schedule the appointments. Carol asked 3 questions. She said, if either of these tests finds something, what would we actually do differently given my age and my overall health? Her physician paused. For the colonoscopy, he said, if we found a large polyp, we would remove it during the procedure. For the carotid ultrasound, he paused again. Honestly, if we found significant stenosis and you had no symptoms, current guidelines point toward aggressive medical management, not surgery. The surgical risk may not be justified. She said, what is the risk of the test itself and of the follow-up procedures it might trigger? He walked through the colonoscopy preparation risks given her mildly reduced kidney function, the electrolyte risk at her age. He acknowledged that a positive carotid result could set off a referral chain that might not serve her best interests. She said, is there a less invasive alternative that gives us similar information? He recommended a fecal immunochemical test instead of colonoscopy. He deferred the carotid ultrasound entirely. Her blood pressure and cholesterol were managed, she had no neurological symptoms, and the USPSTF actively recommended against the test in asymptomatic patients. The appointment ran 20 minutes longer. Carol left with a home test kit. She and her physician made those decisions together, in full possession of the evidence. That is what informed participation looks like. Write these down. Keep them in your phone. Question 1. If this test finds something, what would we actually do differently given my age and my overall health?
This forces the conversation past the test and into the consequences, revealing whether there is a real treatment pathway for you, or whether a positive result simply starts a cascade without a clear destination. Question 2. What is the risk of the test itself and of the follow-up procedures it might trigger? Most patients agree to the first step without knowing they are implicitly agreeing to everything that follows. Question 3. Is there a less invasive alternative that gives us similar information? Fecal tests instead of colonoscopy, medical management instead of surgery for certain cardiovascular findings, active surveillance instead of immediate treatment for slow-growing cancers. These options exist and are evidence-supported, but they are rarely offered unless a patient asks. You are not a passive recipient of medical decisions. You are an informed participant in your own health. Let me bring you back to where we started. The daughter of the man who spent 12 months moving from routine checkup to rehabilitation center shared what had happened at her mother's next appointment. Her mother was 74, independent, healthy. 2 referrals were waiting. The daughter asked the 3 questions. The carotid ultrasound was deferred. The mammogram became a shared decision to continue 2 more years and then reassess. 2 referrals, 2 conversations, 2 decisions made with full information. His mother is still driving herself to appointments. She made it to her 50th wedding anniversary last spring. That is the difference 3 questions can make. Think about the last routine screening test that was ordered for you or for someone you love. Was the cascade explained before the appointment was scheduled? Was the alternative offered? If not, that conversation is still available to you. It is not too late to have it before the next one. Here is what we covered. 1. 5 routine tests: PSA in man over 70, carotid ultrasound in asymptomatic adults, mammography in women over 75, colonoscopy after 80 with significant comorbidities, and cardiac stress testing in asymptomatic older adults carry documented risks that major medical bodies have concluded may outweigh their benefits in those populations. 2. The cascade effect is often more dangerous than the disease the test was designed to catch. 3. 3 questions asked before any screening is scheduled can stop the cascade before it starts. If you're going to use those 3 questions, drop "informed" in the comments right now. If you have a parent or spouse over 70 with a routine exam coming up, send them this video. 30 seconds, they could change everything. If you want to know what to ask before a surgeon presents a consent form, subscribe. That conversation is coming. This is education, not medical advice. Please discuss any screening decisions with your physician. The 3 questions I shared are a starting point for that conversation, not a substitute for it.